The medical goals of care form communicates planned treatment limitations to others, whether this is ambulance officers or other clinicians in the hospital or community setting. It's really a form that allows you to document limitations of treatment that you think would be reasonable for your patient. The form has been divided into 4 sections: A, B, C, and D. And in these, we ask you to consider the patient in categories of curative or restorative, palliative or terminal. For example, Goals of Care A is where it would be reasonable to provide full resuscitation and full medical intervention in the event of deterioration. Goals of Care B is where you feel it would be reasonable to provide some limitations of medical treatment, either through the patient wishes in line with their advanced care directive or where an intervention such as CPR or intubation would not be successful. There is space on the form to document any other limitations you have discussed with your patient, such as IV antibiotics. Goals of Care C, or the 3rd section, is where the patient is palliative, and by palliative we mean the patient's life expectancy is 1 to 2 years. For these patients you would answer no to the surprise question, would I be surprised if the patient died in the next year? And where you are starting to feel a palliative approach is more appropriate. CPR and intubation are automatically not an option, and further limitations can be documented if necessary. The final section, or Goals of Care D, is to document that the patient is in the terminal phase of their life, the last hours to days, where comfort is the mainstay of treatment. So the medical Goals of Care form acts as a summary for treatment limitations of your patient. Once discussed with the patient and family, it can sit with them in times of crisis. Then it acts as a handover to other clinicians such as ambulance officers or those taking over care in a hospital setting.